Interpreting arterial blood gases is a critical skill for respiratory therapists, requiring a strong understanding of acid-base balance, oxygenation, and compensation mechanisms. This section is designed to test your ability to analyze ABG values, identify disorders, and apply your knowledge to clinical scenarios. Whether you're preparing for the board exam or simply reviewing key concepts, these practice questions will help reinforce your understanding and boost your confidence. Take your time, think critically, and see how well you can interpret ABG results. Question number 1. A patient's arterial blood gas results show a pH of 7.56 and a PaCO₂ of 48. Based on these values, how would you interpret the patient's acid-base status? A. Respiratory alkalosis. B. Respiratory acidosis. C. Metabolic acidosis. D. Metabolic alkalosis. Explanation. When interpreting an ABG, the first step is to analyze the pH. A pH greater than 7.45 indicates alkalosis, while a pH lower than 7.35 indicates acidosis. If the pH falls within the normal range of 7.35 to 7.45, it suggests either full compensation or a normal ABG. In this case, the pH is elevated at 7.56, which confirms that alkalosis is present. That immediately rules out respiratory acidosis and metabolic acidosis. The next step is to determine whether the alkalosis is respiratory or metabolic. In respiratory alkalosis, the PaCO₂ would be low because of excessive carbon dioxide elimination from hyperventilation. In metabolic alkalosis, the PaCO₂ may be normal or even elevated, since the body often tries to compensate for increased bicarbonate by retaining CO2. In this example, the PaCO₂ is increased to 48 rather than decreased, so the alkalosis cannot be respiratory in nature. Instead, the elevated PaCO₂ reflects the body's effort to compensate for metabolic alkalosis. With that in mind, the only correct conclusion is that the patient has metabolic alkalosis. The correct answer is D. Metabolic alkalosis. Question number 2. A 33-year-old male patient has the following arterial blood gas results: pH of 7.30, PaCO₂ of 22, bicarb of 12, base excess of -13, PaO₂ of 110. Based on this data, which of the following is the most accurate interpretation? A. Metabolic acidosis. B. Metabolic alkalosis. C. Respiratory alkalosis. D. Respiratory acidosis. Explanation. To determine the correct answer, let's work through the ABG step by step. The pH is 7.30, which falls below the normal range. This confirms acidosis, allowing us to rule out metabolic alkalosis right away, since alkalosis would require an elevated pH. Next, we must determine whether the primary problem is respiratory or metabolic. The PaCO₂ is 22, which is below the normal range of 35 to 45. Normally, a low PaCO₂ points to respiratory alkalosis, but in this case, the pH is acidic, not alkaline. That means the low PaCO₂ must be a compensatory response rather than the primary disorder. Looking at the bicarbonate level, we can see that it is decreased to 12, far below the normal range of 22 to 26. A low bicarbonate value is the hallmark of metabolic acidosis, and the base excess of -13 further confirms that the primary disturbance is metabolic. Compensation must also be considered. Because the PaCO₂ is low, the body is clearly trying to compensate for metabolic acidosis through hyperventilation by blowing off carbon dioxide in an effort to raise the pH. However, the pH remains acidic, so this is only partial compensation. With this analysis in mind, we can eliminate respiratory alkalosis since the pH is not alkaline and respiratory acidosis since PaCO₂ is not elevated. The correct conclusion is that the patient is experiencing partially compensated metabolic acidosis. The correct answer is A. Metabolic acidosis. Question number 3. An adult patient is admitted to the emergency department after a motor vehicle accident. The patient is visibly hyperventilating and has signs consistent with a flail chest, including paradoxical chest movement and respiratory distress. Based on this presentation, which of the following arterial blood gas results would most likely be observed? A. Increased pH and decreased SaO₂. B. Increased pH and increased SaO₂. C. Decreased pH and decreased SaO₂. D. Decreased pH and increased SaO₂. Explanation. To correctly answer this question, we need to look at two key factors from the patient's presentation. First, hyperventilation leads to rapid breathing and excessive elimination of carbon dioxide. Because carbon dioxide acts as an acid in the body, its removal raises the pH and produces respiratory alkalosis. Second, the presence of a flail chest means multiple rib fractures have caused paradoxical chest movement. This impairs ventilation, reduces oxygen exchange, and results in hypoxemia, which lowers the arterial oxygen saturation. With these points in mind, the correct response is that the patient would show an increased pH and a decreased SaO₂. Hyperventilation explains the alkalosis, while the impaired ventilation from the flail chest explains the oxygen desaturation. The other answer choices can be ruled out because they do not align with the physiology. An increased SaO₂ is unlikely in this situation, and a decreased pH would suggest acidosis, which does not fit with the patient's hyperventilation. The key takeaway here is straightforward. When a patient is hyperventilating, you should expect respiratory alkalosis reflected by an elevated pH. When a patient has a flail chest, you should expect hypoxemia reflected by a decreased SaO₂. The correct answer is A. Increased pH and decreased SaO₂. Question number 4. An adult patient experiencing a mild asthma attack is admitted to the emergency department. Based on their clinical condition, which of the following arterial blood gas values would most likely be observed? A. pH of 7.30, PaCO₂ of 49, PaO₂ of 61. B. pH of 7.32, PaCO₂ of 51, PaO₂ of 51. C. pH of 7.46, PaCO₂ of 47, PaO₂ of 52. D. pH of 7.49, PaCO₂ of 30, PaO₂ of 62. Explanation. To determine the correct answer, we need to understand the expected ABG patterns in a patient with a mild asthma exacerbation. During an asthma attack, airway constriction makes exhalation difficult, but in mild cases, the patient can usually compensate by hyperventilating. This increased breathing rate causes excessive elimination of carbon dioxide, which raises the pH above 7.45 and produces respiratory alkalosis. At the same time, air trapping and ventilation perfusion mismatch often lead to mild hypoxemia, reflected by a slightly reduced PaO₂. Looking at the possible answer choices, the first two both show a low pH and elevated PaCO₂, which indicate respiratory acidosis. That pattern is typical of severe asthma or impending respiratory failure, not of a mild attack, so those options can be eliminated. The third option shows an elevated pH, but the PaCO₂ is also elevated, which doesn't fit the expected pattern of respiratory alkalosis. That leaves the final option, with a pH of 7.49, a PaCO₂ of 30, and a PaO₂ of 62. This combination makes sense. The elevated pH and decreased PaCO₂ confirm respiratory alkalosis, while the mildly reduced PaO₂ matches the expected hypoxemia seen in a mild asthma attack. The key takeaway is that in a mild asthma attack, hyperventilation produces respiratory alkalosis with an increased pH and decreased PaCO₂, along with mild hypoxemia. If the PaCO₂ is normal or elevated instead, that's a warning sign of worsening airway obstruction and possible respiratory failure. The correct answer is D. pH of 7.49, PaCO₂ of 30, PaO₂ of 62. Question number 5. Which of the following patients is in the greatest need of ventilatory support? A. pH of 7.35, PaCO₂ of 61, bicarb of 33. B. pH of 7.40, PaCO₂ of 59, bicarb of 35. C. pH of 7.37, PaCO₂ of 52, bicarb of 29. D. pH of 7.13, PaCO₂ of 66, bicarb of 22. Explanation. To determine which patient requires ventilatory support the most, we need to look closely at the pH, PaCO₂, and bicarbonate values to assess the severity of respiratory failure. All 4 patients have a PaCO₂ level above 50, which confirms hypercapnia. While this is concerning, it does not always demand immediate ventilatory support unless it produces severe acidosis or obvious signs of respiratory distress. The pH values provide the clearest picture. Patient A has a pH of 7.35, which is near normal and consistent with compensated respiratory acidosis. Patient B has a pH of 7.40, which represents fully compensated chronic respiratory acidosis. Patient C has a pH of 7.37, again near normal, indicating compensation. In each of these cases, metabolic compensation has helped keep the pH within or close to the normal range. These patients likely have chronic hypercapnia, and while they should be monitored, they do not require immediate ventilatory support. Patient D, however, is very different. The pH is 7.13, which indicates severe, life-threatening acidosis. The PaCO₂ is elevated at 66, and the bicarbonate level is normal at 22, showing little to no metabolic compensation. This points to acute or uncompensated respiratory failure. Therefore, patient D is the one in urgent need of ventilatory support. Non-invasive positive pressure ventilation may be attempted, but if the patient fails to improve or deteriorates, immediate intubation and mechanical ventilation will be required. The correct answer is D. pH of 7.13, PaCO₂ of 66, bicarb of 22. Question number 6. A patient is receiving mechanical ventilation in the SIMV mode with an FiO₂ of 35%. The latest arterial blood gas results are as follows. pH of 7.53, PaCO₂ of 27, PaO₂ of 84, bicarb of 24. Based on these ABG findings, what is the most accurate interpretation? A. Respiratory acidosis with hypoxemia. B. Acute hypoxemic respiratory failure. C. Uncompensated respiratory alkalosis. D. Hypercholeremic metabolic alkalosis. Explanation. To correctly interpret the ABG, we'll analyze each value in sequence. The pH is 7.53, which is elevated and therefore indicates alkalosis. Because it lies outside the normal range, this represents an uncompensated state. The PaCO₂ is 27, which is decreased, pointing toward a respiratory cause of the alkalosis rather than a metabolic one. The bicarb level is 24, which is within the normal range and confirms the alkalosis is not metabolic and that no metabolic compensation has occurred. The PaO₂ of 84 is within the normal range, so there is no significant hypoxemia. With that in mind, we can evaluate the answer choices. Respiratory acidosis with hypoxemia is incorrect because the patient has alkalosis, not acidosis, and the PaO₂ is normal. Acute hypoxemic respiratory failure is also incorrect, since a PaO₂ of 84 does not meet the threshold for hypoxemic respiratory failure. Uncompensated respiratory alkalosis is the correct answer. The elevated pH and low PaCO₂, together with a normal bicarb level, confirm acute uncompensated respiratory alkalosis, commonly resulting from hyperventilation due to ventilator settings or patient response. Hypercholeremic metabolic alkalosis is incorrect because metabolic alkalosis would be reflected by an elevated bicarb level, which is not present here. In summary, this patient is experiencing uncompensated respiratory alkalosis, likely due to excessive ventilation, such as a high-minute ventilation in SIMV, which is leading to hypocapnia. In this case, ventilator adjustments aimed at reducing hyperventilation may be necessary. The correct answer is C. Uncompensated respiratory alkalosis. Question number 7. A 54-year-old female patient who is breathing room air has the following arterial blood gas results. pH of 7.30, PaCO₂ of 57, PaO₂ of 61, bicarb of 24. Based on this data, which of the following is the most accurate interpretation? A. Normal blood gas with mild hypoxemia. B. Fully compensated metabolic acidosis with mild hypoxemia. C. Acute respiratory alkalosis with mild hypoxemia. D. Acute uncompensated respiratory acidosis with mild hypoxemia. Explanation. To correctly interpret the ABG, we'll work through each component systematically. The pH is 7.30, which is below the normal range. This confirms acidosis, allowing us to immediately rule out a normal blood gas and any form of alkalosis. Next, we must determine whether the acidosis is respiratory or metabolic. The PaCO₂ is elevated at 57, which is above the normal range. Meanwhile, the bicarb level is normal at 24, meaning the kidneys have not yet begun compensating. This combination confirms that the disturbance is respiratory in nature and uncompensated. The oxygenation status also provides important context. The PaO₂ of 61 is below the normal range and indicates mild hypoxemia. Now, let's look at the possible interpretations. The idea of a normal blood gas with mild hypoxemia is incorrect because the patient clearly has acidosis. Fully compensated metabolic acidosis is also incorrect because the bicarbonate level is normal and the primary issue is respiratory. Acute respiratory alkalosis does not fit either, since the pH is acidic, not alkaline. The only explanation consistent with these values is acute uncompensated respiratory acidosis with mild hypoxemia. Because the patient's condition is uncompensated and associated with hypoxemia, this is serious and could progress to respiratory failure if not addressed. The correct answer is D. Acute uncompensated respiratory acidosis with mild hypoxemia. Question number 8. A 58-year-old female patient is receiving volume control assist control ventilation with the following settings: respiratory rate of 12 breaths per minute, tidal volume of 450 milliliters, FiO₂ of 40%. Her arterial blood gas results are as follows: pH of 7.35, PaCO₂ of 44, bicarb of 22, base excess of 0, PaO₂ of 91, SaO₂ of 97%. Based on this information, which of the following actions would be most appropriate? A. Decrease the minute ventilation. B. Discontinue mechanical ventilation. C. Administer IV bicarbonate. D. Maintain the current settings. Explanation. To determine the best course of action, we must first look at the ABG results alongside the ventilator settings. The pH is 7.35, the PaCO₂ is 44, and the bicarb is 22. Each of these values falls within the normal range, and the base excess is 0, showing that there is no significant metabolic disturbance. Altogether, this indicates a normal acid-base balance, meaning there is no need to adjust ventilation to correct pH or carbon dioxide levels. Oxygenation is also appropriate. The PaO₂ is 91, which is within the normal range, and the oxygen saturation is 97%, confirming that the patient is oxygenating well. Since both oxygenation and ventilation are normal, there is no need to alter the FiO₂ or PEEP. Now consider the possible actions. Decreasing the minute ventilation would be inappropriate because the PaCO₂ is already within the normal range. Discontinuing mechanical ventilation is also incorrect because while the ABG values are normal, extubation depends on more than blood gases. It also requires a successful spontaneous breathing trial, intact airway protection, and sufficient respiratory muscle strength, none of which are mentioned here. Administering intravenous bicarbonate would be unnecessary since the bicarbonate level is normal and there is no evidence of metabolic acidosis. That leaves maintaining the current ventilator settings, which is the correct choice. The ABG results confirm that the patient is ventilating and oxygenating effectively, so no immediate intervention is required beyond ongoing monitoring. The correct answer is D. Maintain the current settings. Question number 9. A 61-year-old male patient recovering from post-abdominal surgery has been receiving high-flow nasal cannula therapy at 20 liters per minute for the past 3 days. His latest arterial blood gas results are as follows: pH of 7.39, PaCO₂ of 43, PaO₂ of 157, SaO₂ of 99%, bicarb of 24, base excess of +2. Based on this information, what is the most appropriate action to take? A. Decrease the flow. B. Decrease the FiO2. C. Decrease the flow and FiO2 together. D. Switch to a standard nasal cannula. Explanation. To determine the best course of action, we need to analyze the ABG results alongside the patient's oxygen therapy. The pH is 7.39, the PaCO₂ is 43, and the bicarb is 24. All of these values are within their normal ranges, so there is no acid-base disturbance. Oxygenation, however, tells a different story. The PaO₂ is 157, which is well above the normal range of 80 to 100, and the oxygen saturation is 99%. This indicates over-oxygenation. Delivering too much oxygen can lead to complications such as oxygen toxicity and absorption atelectasis, so lowering the oxygen level is necessary. When we consider the management options, decreasing the flow is not the right choice. On a high-flow nasal cannula, flow mainly affects inspiratory support and carbon dioxide washout rather than oxygenation. Reducing the flow could compromise therapy without addressing the problem of excess PaO₂. Switching to a standard nasal cannula is also not appropriate at this stage because the patient may still need the benefits of high flow and heated humidification. Reducing both flow and FiO2 together is generally avoided unless absolutely necessary, because changing two variables at once makes it harder to assess the response. The best option is to decrease the FiO2. Since the PaO2 is much higher than needed, lowering the FiO2 will bring oxygen levels back toward the target range of 80 to 100 while still maintaining adequate oxygenation. Flow should remain unchanged to ensure proper delivery and humidification. The correct answer is B. Decrease the FiO2. Question number 10. A 43-year-old male patient is admitted to the emergency department with a suspected drug overdose. He is receiving oxygen via a non-rebreather mask, but remains unconscious and is making no respiratory efforts. The patient weighs 57 kilograms, and his ABG results are as follows: pH of 7.28, PaCO₂ of 74, bicarb of 20, PaO₂ of 315. Which of the following would be the most appropriate intervention? A. Apply BiPAP with an IPAP of 20, an EPAP of 5, and an FiO2 of 30%. B. Intubate and apply SIMV with a tidal volume of 600 milliliters, rate of 6 breaths per minute, and an FiO2 of 40%. C. Intubate and apply assist control ventilation with a tidal volume of 450 milliliters, rate of 12 breaths per minute, and an FiO2 of 50%. D. Apply CPAP at 10 and an FiO2 of 100%. Explanation. To determine the best course of action, let's start by analyzing the patient's clinical condition and the ABG results. The pH is 7.28, which indicates acidosis since it falls below the normal range. The PaCO₂ is severely elevated at 74, confirming acute respiratory acidosis. The bicarb level is slightly low at 20, but not enough to fully compensate, which means this is primarily a respiratory problem. Taken together, the patient is in acute respiratory failure due to CO2 retention, most likely caused by opioid-induced respiratory depression. Next, we must consider oxygenation. The PaO₂ is extremely high at 315, which is likely the result of the non-rebreather mask delivering 100% oxygen. While oxygenation is excessive, the primary issue here is inadequate ventilation. Now we can evaluate possible interventions. Non-invasive ventilation such as BiPAP would not be effective because it requires the patient to have spontaneous breathing effort, and this patient is unconscious and not breathing. SIMV at a tidal volume of 600 milliliters with a rate of 6 breaths per minute is also inappropriate. The rate is too low to correct severe hypercapnia, and since the patient is not breathing spontaneously, SIMV would not provide full ventilatory support. CPAP at 10 with an FiO2 of 100% is also the wrong choice, because CPAP only supports oxygenation, not ventilation, and cannot clear CO2 when the patient has no respiratory drive. The best intervention is to intubate and initiate assist control ventilation. The recommended initial settings would be a tidal volume of 450 milliliters, which is appropriate for this patient's ideal body weight of 57 kilograms, a rate of 12 breaths per minute to ensure adequate ventilation and lower the PaCO₂, and an FiO2 of 50% to correct the excessive oxygenation. This provides full ventilatory support, which is exactly what an unconscious apneic patient requires. The correct answer is C. Intubate and apply assist control ventilation with a tidal volume of 450 milliliters, rate of 12 breaths per minute, and an FiO2 of 50%. Get access to more practice questions and explanations. I hope these practice questions were helpful. As previously mentioned, ABG interpretation is an essential topic not only in your career, but also when preparing for the board exam. In our experience helping thousands of students pass the exam, one of the best ways to prepare is by practicing with high-quality exam-style questions. Our test bank is the perfect resource, offering hundreds of premium practice questions and full-length practice exams designed to mirror the actual format of the real thing. The questions focus on all the most critical topics, which can help you build confidence and sharpen your test-taking skills. Each question comes with a detailed explanation to reinforce your understanding and ensure you know why each answer is correct. Plus, with topic-specific quizzes, you can focus on all the high-yield areas that matter most, including ABG interpretation. You can get instant access now on our website at respiratorytherapyzone.com. Build your knowledge gradually. Another effective way to prepare for the board exam is through consistent incremental learning. That's exactly why we offer daily practice questions delivered straight to your email. By working through a single question each day, you can build knowledge steadily without ever feeling overwhelmed. These daily questions act as reinforcement, giving you manageable bits of information that fit easily into your routine. Using our proven RRT retention method, each question is designed not only to test your knowledge, but to strengthen long-term retention, so the concepts will stick with you on exam day. Every answer comes with a detailed rationale, helping you understand why the correct choice is right and why the other options are not. This deeper level of learning makes it easier to apply what you've studied to similar questions on the actual exam. Daily practice also helps you avoid the stress of last-minute cramming. By spreading your preparation out over time, you'll approach the exam with greater confidence. And best of all, this routine fits any schedule. Answering one question a day takes only a few minutes, but the impact builds quickly. This is especially true for those who commit to making this part of their morning routine. Over time, you'll find that this steady practice gives you a strong foundation of knowledge, and it does so without ever becoming overwhelming. You can get access to daily practice questions on our website at respiratorytherapyzone.com.